Assalamu alaikum. Okay, let's dive into an important topic today. Today's topic is lymphangitis. Lymphangitis. In lymphangitis, there is cutaneous injury and pathogen invasion of lymphatic in the deep dermis. Pathogen invasion of lymphatics in the deep dermis and strep pathogens and MMSA like methicillin sensitive staph aureus are the organism. There is tender erythematous streak proximal to the wound. Tender erythematous streak proximal to the wound. There is regional tender lymphadenopathy, lymphadenitis. There may be systemic symptoms, fever, tachycardia, and cephalexin is the drug of choice. This is a very important. Lymphangitis. Remember cephalexin. Lymphangitis, deep dermis. Differential is sporotrichosis, which takes weeks to grow, but it these lymphangitis happen within a days. So it is important. Sporotrichosis, it takes weeks to grow. So after that, I would like to discuss about idiopathic anemia of aging. Idiopathic anemia of aging. Elderly patient may present an additional challenges in acute anemia besides other potential comorbidities that can cause chronic anemia at baseline like renal insufficiency, myelodysplastic syndrome, occult malignancy. A significant number of elderly patients will have baseline anemia for which no etiology is apparent. It is called idiopathic anemia of aging. So hemoglobin is low, but you are not finding the cause. It is idiopathic anemia of aging. That means significant number of elderly patients will have baseline anemia and for which no etiology is apparent. They are also more commonly to have additional comorbidities such as congestive heart failure, chronic lung disease, which makes them tolerant even mild anemia. Okay, now the most important topic is blood transfusion. Okay, we will discuss this blood transfusion in detail. What are the indications for specialized RBC treatment? Irradiated RBC. Irradiated RBC for bone marrow transplant recipient, for blood component donated by first or second degree relative. So in that case, irradiated RBC should be given in bone marrow transplant recipient and blood component donated by first or second degree relative. And leukocyte, this one is irradiated. Leukocyte is reduced in chronically transfused patient. Leuko-reduced RBC should be given. And in CMV or seronegative at risk patients, as AIDS patient, transplant patient, potential transplant recipient, and washed RBC for IgA deficiency, for complement dependent autoimmune hemolytic anemia, and continued allergic reaction like hives with red blood cell transfusion despite antihistamine treatment. Washed RBC should be given in IgA deficient patient for continued allergic reaction with RBC transfusion despite antihistamine testing. So the blood transfusion reaction from 0 seconds within minutes, anaphylaxis happens. Acute hemolytic minutes to hours, and from 1 hour to 6 hour, that is febrile non-hemolytic transfusion reaction and transfusion related acute lung injury. and usually 6 hours 2 days. Now there is not that significant transfusion effect is present, and delayed called from 2 days to up to 10 days. So 0 to minutes is anaphylaxis, from minutes to 1 hour acute hemolytic, from minutes to 1 hour acute hemolytic, from 1 hour to 6 hours febrile non-hemolytic, and transfusion related acute lung injury, and for 2 days to 10 days delayed hemolytic. Okay, blood okay, blood transfusion reaction associated with hypotension. Blood transfusion reaction associated with hypotension. Anaphylaxis, transfusion related acute lung injury, primary hypotension reaction, and bacterial sepsis. Rapid onset of shock, angioedema, urticaria, respiratory distress um, within few seconds to minutes of transfusion. It is due to recipient's IgA antibodies. And trolley happens within 6 hours of the transfusion, caused by anti-leukocyte antibody. Trolley is anti-leukocyte antibody, and anaphylactic is anti-IgA. Anaphylactic is anti-IgA antibody. So anaphylactic is anti-IgA antibody, and trolley is anti-leukocytes antibody. And primary hypotension reaction. In primary hypertension reaction, transient hypotension, often in patients taking angiotensin converting enzyme inhibitors. Transfusion hypotension in patient taking angiotensin converting enzyme inhibitors, and within minutes of transfusion, and caused by bradykinin in patients produced normally degraded by angiotensin converting enzyme. And bacterial sepsis, there may be fever, chills, septic shock, and DIC within minutes to hours of the transfusion. So acute hemolytic transfusion reaction is distinguished from febrile non-hemolytic acute hemolytic transfusion reaction is distinguished from febrile non-hemolytic transfusion reaction by the presence of plasma hemoglobin more than 25 milligram per day, may result in a pink appearing plasma. Plasma-free hemoglobin is less than 25 milligram per day in febrile non-hemolytic transfusion reaction. Cessation of blood product, IV normal saline for hydration. So acute hemolytic transfusion reaction is distinguished from febrile non-hemolytic transfusion reaction by presence of free hemoglobin more than 25 gram per day. There is pink appearing, may result in pink appearing plasma, and plasma free hemoglobin less than 25 is febrile non-hemolytic. Less than 25 is non-hemolytic transfusion reaction. Okay, now transfusion reaction. These boxes very high yield. Anaphylactic, anti-IgA antibody, recipient anti-IgA antibody, acute hemolytic ABM incompatibility, febrile non-hemolytic, cytokine accumulating during blood storage, arterial recipient IgE blood product component, transfusion trolley is donor anti-leukocyte antibody. Trolley is donor anti-leukocyte antibody, and anaphylactic, A for anaphylactic, A for IgA antibodies. Delayed hemolytic is anamnestic antibody response, and graft versus host is donor T lymphocyte. Graft versus host is donor T lymphocyte. These are the cause you must remember. Mainly, especially these three: transfusion related acute. It is anti-leukocyte antibody, donor anti-leukocyte, transfusion related acute lung, L for lung, L for leukocyte. So donor anti-leukocyte antibody. Anaphylactic, A for anaphylactic, A for anti-IgE antibodies. Acute hemolytic is avio incompatibility. Febrile non-hemolytic is cytokine accumulation during blood storage. Graft versus host is GT, donor T lymphocytes. Donor T lymphocytes. Okay. Anaphylactic is within seconds to minute. Acute hemolytic within an hour. Within an hour. Febrile non-hemolytic and Trali is 1 to 6 hours. Within 1 to 6 hours. 1 to 6 hours. Arterial is within 2 to 3 hours. Arterial is 2 to 3 hours. Delayed is within days to weeks. From 2 days to 10 days. And the graft versus host is within weeks. Anaphylactic, there may be angioedema, hypertension, wheezing, shock, IgA deficient recipient. Acute hemolytic fever, flank pain, hemoglobinuria, DIC, positive Coombs test, febrile non-hemolytic fever in chill, urticaria. Transfusion related acute lung injury is non-cardiogenic pulmonary edema with bilateral pulmonary infiltrate. Graft versus host is rash, fever, GI symptoms, and pancytopenia. And bacterial sepsis, minutes to hours, bacterial contamination of the donor product, fever, chill, septic shock, and DIC. Okay, delayed hemolytic transfusion reaction. It is anamnestic antibody response. Antibody production against minor RBC antigen, antibody production against minor antibody, uh, which was previously exposed, which was previously like prior transfusion. Sickle cell patient, pregnancy and transplant. So delayed hemolytic transfusion reaction, it happens in prior transfusion like sickle cell patient, pregnancy and transplant. Onset within more than 24 hours to months after transfusion. There will be low grade fever, jaundice, fatigue, dyspnea, tachycardia. Lab is hemolytic anemia. In hemolytic anemia, indirect hemoglobin is high, LDH is high, reticulocyte count is high, and low hemoglobin and heptos. There is new positive direct antiglobin Coombs test, and it is supportive. Fluid should be given, and prevention review transfusion of the and history prior to antibody screen. Transfuse when necessary with extended antigen cross matched blood. Transfuse when necessary with extended antigen cross blood match. Okay, now transfusion reaction. It is anaphylactic, it is arterial. Anaphylactic is anti-Ig antibody. Arterial is preformed IgE antibody against the soluble antigen in the donated plasma. Anaphylactics seconds to minute, and arterial it within 2 to 3 hours. There is respiratory distress, anaphylactic angioedema, hypertension. In arterial there is hives and itching. There is a hives and itching. In arterial, hives and itching, there is no respiratory distress. Both of them. In arterial, immediate cessation of transfusion, antihistamine, immediate cessation of the transfusion, antihistamine, and resume transfusion if patient is otherwise asymptomatic. And in anaphylactic cases, if there is respiratory distress, there is hypotension, so immediately stop the blood. Epinephrine should be given, antihistamine, oxygen, fluid vasopressor. Okay, after blood is ordered for transfusion, the following compatibility testing is usually performed. First, ABO, then RH type, After the patient's serum is screened for unexposed antibody, a procedure called pre-transfusion antibody screen. A procedure called pre-transfusion antibody screen. Pre-transfusion antibody screening is needed. Pre-transfusion antibody screening is needed to detect any clinically significant RBC antibody. If negative, then this patient can be safely transfused. If positive, then further investigation is usually warranted to evaluate the identified antibody. The major problem that leads to difficulties finding cross-matched blood in a patient with history of multiple transfusion is alloantibody in patient with sickle cell anemia and myelodysplasia. The most implicated RBC antigen in the case is ELK. Moreover, these patients tend to overlap with multiple antibodies that make finding compatible with blood even more difficult. Okay, transfusion overload. This is the transfusion overload. Transfusion overload is age less than 30 and more than 60. So transfusion TACO, transfusion associated circulatory overload. If age is less than 30 and more than 60, cardiac or underlying cardiac or renal function, large transfusion volume, or fast induction rate. There are respiratory distress. Clinical feature less than 6 hours of the transfusion, respiratory distress, increased heart rate, increased blood pressure, increased heart rate, increased blood pressure, and pulmonary edema. Management is respiratory support, oxygen, and diuresis. Respiratory support, oxygen, diuresis. uh, trolley and taco closer to each other, but trolley has hypotension, but taco does not have hypotension. It cause taco cause hypertension, and trolley transfusion related acute lung injury causes hypotension. This is the important differentiating point we need to remember. And finally, the catheter induced septic thrombophlebitis. Catheter induced catheter related bloodstream infection are more common cause of fever in hospitalized patients and can be complicated with catheter-associated septic thrombophlebitis. The infected thrombus serve as needles for microbial proliferation and present with fever and signs and symptoms of bacteremia. The involved vein may display erythema and induration, and that may be purulent drainage from the catheter site. How to diagnose? The diagnosis may be aided by duplex ultrasonography or with contrasted CT scan. In catheter-induced thrombophlebitis, the diagnosis is duplex ultrasonography or contrast CT scan treatment, infectious source control with removal of the catheter and surgical excision of the affected vein, and IV antibiotics. So it is very atypical catheter-induced thrombophlebitis. So we have read the topic of lymphangitis, blood transfusion, and its complications also, indication of RBC transfusion and its complication, and finally catheter-induced thrombophlebitis. Now I will like to see a video where you will find a case. Can you tell me the sign of this video? Okay, look at this lady. He has difficulty standing. Look at his walking. Okay, now look at this. Okay,